What's going on, everyone? Sid Gordon here with Core Medical Podcast. And today we have one of the OGs from Core Medical Group, part of our medical team. I hold her in very high regard. She's a dear friend, an amazing, amazing part of Core Medical, Brianna. Thank you so much for coming on today, and really excited to have this chat.
All right, great. Hi, everyone. How are you, Sid?
I'm doing great. I'm doing great. So, Brianna, talk to us, starting off kind of um, your background with Core, because I know you got out of practitioner school, right?
Yep.
And then basically came aboard with Core pretty much instantaneously. And now you're basically my top PA. You set all the protocols with the physicians. But I'm not going to get into too much. But talk about your responsibilities with Core, and kind of how Core has evolved since you started with me. What has it been, 9 years?
Just about 16. So
Yeah,
yeah,
eight and a
10
half
years.
years.
Been some time.
So
Yeah, so started back in 16. I mean, I know Core was been around for a while at that point, but still wasn't as big as it is now. I saw at that point, I think when I first started, I was working maybe 3 days out of the office up in our Massachusetts offices. We had Norwood and Saugus. And I just said, Sid, I need more. I need more time, more time, more time. Oh, yeah. So I started adding more patients. We got a little bit busy over the couple years that I was in the office up until like 2019, 2020. And then right around COVID, things just started getting busy. We got a little bit busier. Telehealth kind of started to get a little bit busier. I said, what are we going to do? How are we going to do this? But we kind of figured out a protocol where we could make sure we were, monitoring our patients properly with our labs, making sure that they were, still making sure they're getting to see their primary care, and that whole kind of kit and caboodle, which, I think we did a really good job of. I think a lot of other kind of places that were popping up, they did a lot of telehealth, but nobody was making sure that they were getting their double checked, make sure they're getting their vitals, making sure, we're looking at you as a whole human, not just here's some testosterone, have a nice day, but your testosterone level labs, your estrogen, your full red blood cell panel, liver enzymes, kidney enzymes, vitamin D, B12, cortisol, insulin, thyroid, PSA, CA125 if you're a female, iron, total iron binding capacity, ferritin. It's more than what your primary care is doing, not because it's the primary care's fault, but because it's a lot of blood. And they just don't have enough capacity to be doing that in the 15 minutes that they get per patient, where we make sure we schedule enough time per patient to encompass all of that. So with telemedicine, we started getting a little bit bigger. We started seeing patients in other states, and Core grew. And even since then, in office has been insanity too. So I'm booked with patients probably maybe 11 a day plus the, I don't know, 20 so odd emails that we get, each practitioner. And it was just me. So it's just me. You had one PA in Florida and one PA in New York. And now I think we're a total of 8 or 9 PAs. So Core has grown
13 practitioners across the board. Yeah, yeah,
exponentially.
with the doctors. So also, talk to us about talk to the audience about how we've evolved with growth into blood work, and why the additional blood work that we're doing now is so important, because there's a lot of things that you've added to our labs in the last 3 years, and it it doesn't make our job easier. We don't do it to torture the patient. There's a reason for it. And
Yeah.
one of the reasons why I have Brianna on here today is because there's a lot of patients that are like, what is all this additional blood? And they want to understand it. And I said, well, when you speak with your practitioner, they will explain everything. Because if you don't believe me, try it out. They go line by line, especially if you're a brand new patient, everything that's going on. So just talk to us a little bit about when a new patient comes aboard, or even an existing patient, what that patient's going to experience, going through their blood work, and then also talk to us a little bit about the additional bloods that have been added, not only over the last month or two, but over the last two or 3 years.
There's fair. So new patient comes on board, we want to make sure we get a thorough medical history. We want to make sure everything is in good standing before we even introduce testosterone, if that's an option. We want to be looking at you as a whole human. So a lot of these guys, or a lot of patients in general, like, I want to feel better. How can I feel better? So, you have a lot of these TRT clinics that are like, oh, here's some testosterone, but it's so much more than that. We're looking at your test levels, which obviously is important, but we're not just looking at your total. We're looking at your free, we're looking at your bioavailable, we're looking at your SHBG, because you could have amazing total testosterone, but it could be being bound up in your body by certain other hormones, SHBG, sex hormone binding globulin, albumin. And it may not be that you're a candidate directly for testosterone, but something that would just help lower your SHBG, which would give you more bioavailable testosterone to use in your body.
The conversion rate.
Yes,
The conversion rate. Gotcha.
exactly. And then we're also looking at your estrogen, because if your estrogen levels are high compared to your testosterone levels being low, you're also going to feel wonky. So that's why a lot of patients will, the majority of them, but not everyone, will need an estrogen blocker. Usually something called anastrozole Rimidex as the name brand. But they will, kind of thinking about, your testosterone. Once it gets to a maximum point, you then kind of dump over the side of this bowl and you have conversion to estrogen. You want some estrogen, but you don't want as much as a female. High estrogen levels in a male, you get some potentially nipple lumps, nipple sensitivity. And so, you're not going to always get those symptoms, but you'll get other issues, libido, erectile difficulty, moodiness. You'll just feel off, depressed, anxious. I have a lot of patients that, being a TRT clinic, you're going to get a lot of guys that have done a lot of testosterone in the past, and they know their bro science. And they are like, I don't need an estrogen blocker. I don't need an estrogen blocker. They get on the testosterone, they come back 3 months later, I feel terrible, I need more testosterone. They say, are you taking everything as prescribed? Well, I'm not taking this, I'm not taking that. I'm like, let's do some bloods, not taking the estrogen blocker. Estrogen levels should be between sweet spot 15 to 25, guys with estrogen levels of 100, being like, I'm so anxious, I can't sit in my skin. So they take everything as prescribed. 2 weeks later, they're like, oh, okay. So, they feel a heck of a lot better when they take everything as prescribed. Some guys don't need an estrogen blocker, and if they don't, we don't want to prescribe it to you. I don't want your levels to be too low, because then you can have joint aches and pains, osteoporosis. But it's so, so important, because everybody's different. Everyone's going to have different conversion rates and things like that. The majority of patients, in my opinion, from what I've seen on all the bloods for being here for 8-9 years, is that most guys need it unless they are, insanely lean, 5% body fat. They're cutting out alcohol, no tobacco, really low sugar, low refined carbohydrates. They're exercising 5-6 days a week. That's not your average person. Some people are like that, and that is great, and they may not need the estrogen blocker. Also, by doing smaller dosing of the test, every day or a couple of times a week, if you're really like, I don't want to take adjunctive medication. But in a perfect world, testosterone, estrogen blocker, and then something called enclomiphene, ganadorelin, HCG, kisspeptin, one of those other compounds to make sure your testicles don't shrink up. Because not necessarily for the fertility portion, yes, that's important for some guys, but also if you ever want to get off of testosterone in a year, in 2 years, in 5 years, in 10 years, you don't want your testicles to be the size of green peas. I've seen it in practice before, and we don't want to get that small.
That must have been very embarrassing for that man.
I didn't say anything at that moment.
I mean, I
there's
don't think I want to show someone, a female, my pea-sized testicles, especially a pretty woman like yourself, Brianna. So
aside note, I'm not going to be saying this podcast, but when I first started working for Core, I don't even know if you knew this at that point. Some of the coordinators did, and they have laughed at me since. So for the first year, I was feeling every single patient's testicles for the full first year, because the overseeing physician at the time said, you need to feel everyone's testicles. You need to feel everyone's testicles. So I did. And a year into it, I said, well, why am I feeling these testicles? What is the purpose of this? What is the plan when I'm feeling these testicles? If they're small, okay, yeah, we're going to increase, enclomiphene or HCG. But I can ask the patient, hey, do you have any testicular shrinkage? They'll say yes or no. These guys are looking at their testicles every single day.
So that's why we had so many reoccurring patients in the first year, because Brianna was touching all of them.
I was touching everyone's testicles. That was the real reason why we got so many.
I might turn that back into standard protocol.
No, and no. So the reason why I was touching the testicles is because I was supposed to remember what Bob's testicles felt like a year later, and I said,
how's that possible?
I'm supposed to remember what, are you insane? So I was like, what's the purpose? And then the overseeing physician at that point was like, it's all right, you don't have to. And I said, I cannot believe I touched testicles for a full year
Yeah.
because I was supposed to,
That's freaking
be
great. No,
there.
I didn't know that, but I would have given you a really hard time and
I,
probably wouldn't have helped you let you know it wasn't necessary either, but that's great.
that was
Hey,
my
back
hazing.
for a second there. Um, when that new patient comes aboard, whether they're on test or not, I have this thing where when I notice when patients aren't following your procedure, your protocol properly, and it's typically because they feel something from their testosterone. They feel that from their testosterone, and then these other two things over here, they don't feel anything from, right? If you took it by itself. But what I try to tell people is you will feel something negative if you don't take these other two drugs, and then your positive effects of your testosterone will be minimized. So, like, I try to drive that home when a patient calls and they're like, "Yeah, I have 90 inostrozole," and I'm like, "Well, that's great. How do you feel?" And they're like, "Well, I'm a little bloated." All right, well, that's an issue. There's a reason why we we are so far ahead of most other places in making sure the protocols are proper. And like Brianna said too, like everybody is not the same. Like they're just not. So it's going to be different for everyone. Just because your friend came aboard and needs 0.25 milligrams of inostrozole doesn't mean you might not need 1 milligram. Doesn't mean that you might not need a half a cc a test. So there's just a lot of different things that come into play. So pay attention to what Brianna is saying right now. It's very important to understand that this is not a one size fits all situation.
100%. And I think that's why we get a lot of patients coming from other places. They start on TRT, they're like, I felt great for the first 2 months. And then I started feeling like crud. It's because they felt the testosterone, they felt great. The estrogen levels were still, baseline, maybe going up a little bit. But usually, 1 to 3 months in, their estrogen levels start to go up and they're like, I felt great, libido was better, erections were better. And then estrogen levels start to get high, and then it's like, meow, I feel like fraud. And then they end up getting off. They said it was great, but now I feel terrible. And that's why we get so many patients that come to us because they're like, yeah, I was on TRT in the past. I felt good for a little bit, but then I felt like fraud. And that's just screaming, were you taking any, anastrozole? Nope, I don't even know what that is. So that's the reason why. And there's some doctors that say you should not be on anastrozole. Absolutely not. You're gonna get, osteoporosis, joint aches and pains. 100% accurate if your estrogen levels drop. And that goes back to the small dosing daily injections, no alcohol, no tobacco, no very little, no sugar, refined carbohydrates. That's not your average person. If you have that in your diet, if you're doing any of those things, if you are not like 100% on your diet, exercise, and everything else, 5% body fat, you're gonna have estrogen conversion. There are like maybe 5 patients I've seen in the last 8 years that just didn't need the estrogen blocker because for one reason or another. And those guys I said, off, we don't want you on it.
So,
You're not converting.
so there
Perfect.
are a lot of doctors out there that do tell people that. Like, what do you say? What do you, other than that, like, what is the negative effect of that estrogen blocker if you need it?
If you need it, very little. So the estrogen blocker, you're thinking about it. You're using this with breast cancer patients, and people read that and they say, ugh. But what you're getting when you're taking the anastrozole, if you have breast cancer, is 1 milligram every single day, daily, seven milligrams a week. We are prescribing 0.5 twice a week average. Sometimes patients are 0.25 once a week. Some patients are 1 milligram twice a week. That's highest dose, but average, you're getting 0.5 twice a week, 1 milligram total a week. It's a smidge. We don't want to crush your estrogen. We just don't want it to be in the hundreds. We want to keep you dialed in, sweet spot. And I know you'll probably, you go down journal article or whatever the case is, other doctors will say there is no sweet spot. But I promise you, I've seen anecdotally with our patients with estrogen levels in the 70s, 80s, 90s, they all feel terrible. They're trembling in their skin. They feel anxious. They feel bloated. They're walking around not feeling good.
And what's interesting too is that you can, once you've been on testosterone, like I have, like my body tells me when I forget to take it at this point. Like I'm like, oh
Mhm.
shit. Like as I'll like I can feel my emotion change from one day to the next.
Mhm.
And I'm like, oh my God, estrogen blocker. And the next day it's completely different. You know, I take a small dose too. But talk about these are some harder topics that I've spoken about on this podcast quite a bit. Talk about male PSA, CA125 test for females. We've seen some pretty, unfortunate things by having to be the bearer of bad news from those two tests. But when some people ask me like, why are we running this? And I'm like, well, unfortunately, we've found prostate cancer in 40 men in the last 10 years under the age of 45, and we've found ovarian cancer in females that they probably never would have found until they were in their 40s or 50s, and 90% of the time it was stage 1. Talk a little bit about that and like why, if you're not with core, it's really important to be making sure there are certain tests that are not being performed by your GP that you get performed.
Absolutely. So PSA, for example, it's one of those topics where I think that primary cares don't want to go down that road, because if you go down that road and you get a high PSA, okay, now what? The patient's a little bit nervous. You have to go down further investigating, urology, you may need an MRI, you may need screening, but what's the alternative? Okay, we don't check it. What we don't know is better. That's like saying we're not going to do any colonoscopies. We're not going to do any mammograms. We're just going to avoid all screening tools, because what if it does come back? And so it's not even just the number that we're looking at. If we have a new patient and they come back and they're on a high, I'm like, listen, first and foremost, before we even touch testosterone, let's get this PSA worked up. The new research with PSA and testosterone, it's controversial. A lot of the new research says testosterone is not going to cause prostate cancer growth, but we're still kind of stuck in some of the Stone Age. So I still would rather be better safe than sorry. Let's get a full workup of the prostate. Because if it does come back and it is high in your 40s, 50s, 60s, I just had a patient who was 60 years old. This was just this week. And his PSA was at 14. And I said, have you ever had this checked before? And he goes, no. And I said, but have you been to your primary care? And he said, yes. And I said, are you sure? He goes, they've never checked it. They just asked me if I have any symptoms, like, any urinary symptoms, things like this, the things that you just asked me. And I said, well, it's high and you're asymptomatic. I need you to get this checked out. And he said, okay, I promise. I will literally call my primary care right now, get urology referral, and I guess we'll see what happens. But had he not come to us, hopefully it's benign. Hopefully it's just, you can have an elevated PSA with an enlarged prostate, so BPH. Fortunately, as you get older, prostate gets a little bit larger, causes some urinary issues. Could be elevated because of that. Could be elevated because of prostatitis. Could be elevated because I've seen this in the past too with some of our patients, which we've been talking to try to avoid. Avoid masturbation, intercourse, riding a bicycle, ideally 3 days prior to labs, because those things.
Who can do that?
Well,
no, I mean the bicycle, Let's keep going.
Bicycle, fine. All right. Don't avoid the other things, but if it comes back high, then you have to retest. I had a patient who was, masturbating several times a day, and his levels were 7 on the labs. I said, cut it out for at least, if you can, 3 days. Levels went back to 0.5. That's not your normal case scenario, but it goes to show that it definitely can cause an elevated PSA. So if you can avoid
that guy needs more. That guy needs more than a retest.
Fair. But yes, so that can sometimes cause an elevated PSA. But if that's not the case, if you're not that end of the spectrum, and it's important to get it checked out, because we have found prostate cancer, and it's so important because we just want to make sure we're taking care of you, not just for your testosterone, but for anything like that. Same thing with the CA125. We've had patients with elevated CA125s, and there's been ovarian cancer, because ovarian cancer is the scary one where there's no symptoms until there's symptoms. And then once the symptoms are there, it's
too late.
It's way beyond what there's anything you can do. And it comes back and it's high. Again, you're not going to get checked with primary care only because they say, okay, it comes back and it's high. It could be an ovarian cyst, fibroid, it could be things like that. But again, if it comes back high, do a little bit more digging and figure it out, as opposed to just say, rather, close your eyes, not know it all.
I mean, I get Christmas cards still from families from 10 years ago that we found prostate cancer. And I had a woman call me maybe, I don't know if it was your patient or not, maybe a month ago that, she ended up having ovarian cancer, had to have everything removed and, called me like, just has a 4-year-old and a 7-year-old and was like, these kids wouldn't have seen me past their 20s, like I would have been bad. And so going back to when you're seeing your general practitioner, because I tell everyone now, Core Medical is so blessed. Like we are a household name, um, and we're not here to sell you on anything, but we're here to educate you, right?
Mhm.
So right now, and we'll put this below as well, and we'll probably make it a clip on top of that. Tell us what additional tests you should be demanding from your GP when you go in, other than CBC and comp metabolic panel.
So it's not the primary cares that I have to blame by any means. It's the insurance. So I don't know if I told you this either. When I first started working with Core 8 years ago, I said, my insurance is pretty good. I'm sure that my insurance will cover all these testings, the CBC, the CMP. That's what they normally do with primary care, and sometimes they'll check your A1C. But let me just run it through my insurance.
Yep.
I'm not kidding you. It was $3,500. I remember calling Charlie because I was still new and I'm like, oh my God, like, what am I going to do? I'm literally going to throw up $3,500. I should have just paid the 300, 350, whatever the heck it is for the blood work. Like, what was I thinking? And so Charlie was like, relax, everything's fine. Like, we could pull it onto our account. Thankfully, you did it with our, LabCorp, you run to that, blah, blah, blah. But it's not the primary cares, it's insurance. If insurance is not going to cover it, if you have the deductible, if you have a copay, no, it's deductible, not copay.
Well,
So if your deductible is 20%, 10%, the panel being, it's usually between $2,500 and $3,500, you're gonna get slapped with a $300 bill, sometimes more than that.
exactly.
Especially if you have a deductible to meet. So if you have a deductible to meet, if your deductible is 1,000, 2,000, well, then you're gonna be paying that $2,000 up to
The
2,000.
highest bill I've seen was $4,200 for our panel that someone demanded that they were going to have covered. But when I walk into my general practitioner's office and I want to add a panel, does that person have the ability to cash pay that panel?
Mm-mm.
No.
I don't think so. I think some states, but no, they have to put their insurance. They just don't have the ability. You know this because of the quantity of patients we see. You get an amazing deal because we're seeing X amount of patients. You're able to get the blood at a ridiculous cheaper pricing because they're not pushing through insurance.
And,
Um,
and the other thing too is this, which I do want to touch on: pound for pound, panel for panel. There is not a cheaper company that there's not a place you can get this panel done cheaper anywhere. And I'll challenge anybody out there. For what we offer, you can take our blood work anywhere, but 95% of the other practices out there, we will not accept their blood work in completion. Accurate, Brianna?
100%. They don't pull enough. And it's, again, not their fault. They just don't. You've been around for, even before I was here, is it 12, 13, 14, 15 years? When did you start?
Well, it'll be 15 years this October.
Yeah, so it just grew. The panel, I'm sure, when you first started was testosterone, estrogen, CBC,
Yeah, it
CM,
was a basic
yeah,
it was a basic panel.
basics.
Yeah.
And that's what most places offer because that's what they say, okay, these are the main things I need for TRT. But then we started growing and growing and looking at just the insides of people and realizing that, oh, your energy levels are down. It could be testosterone, it could be your thyroid, could be related to your iron levels being deficient. So many other things besides just that. So it just grew into this massive panel, which, just like you said, you're not gonna, at least in my opinion, from what I've seen, you can't get this anywhere per test. And that's what I say to some patients. Some patients come in and they're skeptical, and I say, listen, I'm literally not trying to sell you anything. We will go over your blood work. You can leave here with the copy of your bloods with the recommendations and tell me you want nothing at all, and
Yeah.
that is fine. Just, if your vitamin D levels are low, take some vitamin D. If your cholesterol, everything else is out of whack, you should address these things, but I'm not forcing anything on you. I just want you to be a better, healthier human for yourself so that, you live a better life, and not even just live longer. It's, you want to live healthier. You want to be able to move. There's a handful of patients, but we have a couple older patients, 70-year-old patients. And I remember I just saw him a couple months ago. He walked in the office and I always say, okay, this is your birthday, because I'm going to take their bloods. And I'm like, is this your birthday? He was 70 years old. I said, are you sure this is your birthday? And I looked, and he's been with Cora for like 10 years. And I said, I cannot believe you're 70 years old. You literally look like you're 50 years old. Like, I want to be you when I grow up. Because it's not even just like, oh, it's the testosterone, that's it. It's the testosterone that helps him with his energy, with his motivation, with the body composition, with the mental clarity. He was sharp as a tack. Like, I just, it was crazy. And so testosterone plus healthy lifestyle, he just was my optimal patient. So
The
I know I'm on a tangent for always.
No, 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 no. This is
One
amazing.
more thought.
This is like amazing stuff, because the reality of it is that a lot of people watch this, and it's the fear of the unknown that make people not move forward in a lot of directions in life, right? And our brains go to these places of, oh my God, that's going to be so overwhelming. But what it all comes down to is just get the fucking blood work done,
Exactly.
and then we'll go from there, and then we'll take another step, and then we'll take another step, and we have plenty of staff to help you along the way, and the great news is this, right? Between like Brianna and Betsy, they've basically trained all of our other practitioners. So what you're getting from this call is what you're going to be getting from the other people. We set a very high standard here. And if people aren't providing this information at Core Medical, they're no longer with Core Medical. I don't rule this place with an iron fist, but I also stay out of the clinical side of things because, guys, guess what? Not my forte. I don't have the degrees to back it up, but I found the right people that do. And you're more than welcome to get the blood work done here, to go somewhere else to get a consultation. I beg you to go ahead and do that, because it just makes us look that much better. So one thing that I'm thinking about now, if you are out there, you're hearing this, and you want to just get blood work done, just so you're aware, when you call us, you can get a panel done. You can call us and buy a panel and just say, I just want to get a panel done, and we'll get you a panel. It's no problem. But you should definitely take advantage of the telehealth visit as well, because your general practitioner doesn't go through as much blood as our team does on a daily basis. I mean, we're seeing between 10 and 15 people per day per NPPA and doctor. So that leads me into the next thing. The next thing is that I went out on a limb the other day on my podcast, and I said, you know what? Since we've started telehealth, because we do make the patient once every 8 months go in and see their practitioner and get touched, get a copy of their physical exam. It goes inside the chart. We can see their blood pressure. We know that they're seeing another doctor that's putting hands on them. I went out on a limb, Brianna, and I was waiting for this to throw at you. I venture to say telehealth right now is actually better medicine in some situations than an in-house visit with the MD, NP, or PA, simply because people are more vulnerable. They're in their home. They're not rushed. They're not waiting in a waiting room a half hour to see somebody. Even though when you go to one of our practices, we schedule our time very efficiently, so you're not waiting for too long. But at the same time, we need to keep into consideration that, like, when you're in your house and you're slowed down and you're not frustrated, you just waited for 2 hours, that those visits seem to go a little bit better. Would you agree or disagree with that?
I agree. Because you're also thinking about the patient comes in, they're nervous. I'm sitting in front of them. I may ask them to touch their testicles. No, I don't. But they get nervous. Their blood pressure goes through the roof, because they're sitting there nervous, like, okay, I'm going to have to talk to this woman about my erectile difficulties. And at this point, I've literally heard everything under the sun. You couldn't say anything that I haven't heard at this point, but people are still nervous. They don't like to go into doctor's offices. I think it's important that so again, with coming into the office, those patients, they should be seeing their primary care, but I'm not forcing that down. Like, I'm not forcing that this has to happen no matter what, because I am putting my hands on them. I am getting their blood pressure, their vitals, listening to their heart and lungs. But by having, your primary care, at least in conjunction with our care, you're getting a physical with them. Usually you're getting another set of bloods, not a crazy set of bloods, but they're at least getting a minimum, and they're having someone to back you up if you, God forbid, yes, get a cold, get a cough. It's someone that's also monitoring you long term. They have urgent cares for all those things, but I always urge patients to get in to see their primary care, because it's important for long term health. you get, I also have them share our bloods with primary care. I say, send them our panel of blood so that
Yeah,
they, recognize, hey, I'm gonna put this in
exactly.
the chart. And even if they stop with core in 5 years, in 2 years, at least the primary care will be able to see everything in the history that they've
Mhm.
had done through us. And sometimes it may make them say, all right, let me try, their vitamin D levels were, normal is 30 to 100, sweet spot's 50 to 80. Their levels were 10 for 2 years in a row. They started vitamin D. Let me just continue to monitor that number. So I do agree. You can come into the office. It's great. Like to see you there. But if you do telehealth as well, you're going to be in the comfort of your own home. You're not going to be in traffic, rushing, but really important to see your regular primary care for your annual visits. And big thing, we also, which I don't think a lot of other telehealth places even recommend, even some of the primary cares, which is a little scary. But I say, listen, you haven't seen your primary care in 2 years, like send me on over a blood pressure reading before we even consider starting
Yep.
anything. I'm gonna make sure that you have normal blood pressure. We're not gonna start anything testosterone, peptides, anything at all. Send me on over a blood pressure reading. And I'm not telling you that you have to go XYZ. Get a cuff, Amazon, CVS, Walgreens. Stick your arm in a cuff at CVS. Some of those don't exist anymore, but any of those things, just so that I can make sure that your blood pressure's in check. I had a patient, back to another patient, but patient with like a 180 over 110 blood pressure. He hasn't seen his primary care in like 3 years. And I said, you need to go to urgent care. Like, I am nervous that you're going to walk out of here and have a cardiovascular event. Please, 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 please. He did got on, I think, 2 blood pressure medications and was normal. And then at that point, we proceeded to treat him for his low testosterone. But had he have been gone to another clinic, they would have just said, okay, yeah, all right, here's some testosterone. We're not really going to think about your 180 over 100 blood pressure. You have a heart attack or a stroke. Oopsies. Like, it just, you want to make sure if you are to go to another place, you want to make sure that they're doing their due diligence, making sure they're doing the bloods, the blood pressure, really looking at you as a whole person, not just as a sale. Because that's unfortunately a lot of what our economy is. It's sales, 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 but each person is a person and not just testosterone. It's whole person.
The thing I get a lot is from our patients, Brandon. They're like, well, after meeting with your medical team, like I don't even want to go see my GP anymore because you guys have accomplished so much, and told them stuff they didn't know. Like, I mean, how would you know if your vitamin D is low if you're not testing your vitamin D? Well, I can just tell you, 90% of the people that are walking the face of the earth need vitamin D at this point. It gets worse and worse each year. Next year it'll be 91% and then 92 because of the way our lifestyles have changed quite often and kids aren't playing outside.
Mhm.
People aren't going for walks anymore. There's a lot more TV time and social media time and the only way we can get vitamin D is 15 to 20 minutes of direct sunlight a day. Is that accurate?
Something like that.
And
But it
then
also, so too,
and
your
then your
body's,
absorption rate and all the whole of that through your skin, and it's a hormone. So I mean, it is something very easy to get at Walgreens or CVS, and we do offer to put it inside testosterone to make it so it's very mindless, which I really suggest if you're a female and you're not on injectable testosterone. We also prescribe pharmaceutical grade medication, but still give, because we know of your financial situation, we give referrals to go to Amazon to buy shit all the time. So it's like not a, and I don't care about that. Like, I'd rather you be able to afford these protocols for a long period of time rather than be a one and done and then super frustrated that it affects your bank account. Like, we're not here to do that. And the best part about it right now is that like we're providing so many results, Brianna, that it just causes this massive influx of new patients because every person that comes across that feels better, looks better, loses weight, shows more energy, is more productive at work is legitimately a billboard to their entire audience.
yeah.
And whether we treat you as a dollar sign or we treat you as a person, the results from those two things are very, very fucking different. So, that's been a really, and I really have to thank the medical team for that. The people that do the onboarding, fantastic medical teams, great. But without like having that real, one-on-one time with a practitioner, like this would not be possible. And and we've really grown there. So Brianna, before we wrap up, Talk to us real quick. Talk to the audience real quick about if you're out there and you're experiencing X, Y, and Z types of symptoms at certain ages. What are some of the dive deep here symptomatically of of signs that you may be leaning towards a position of needing to get blood work done for hormones or for other things? Or I mean, I know that you think everyone should probably get this panel done over the age of 25, whether they need
Yeah.
it or not. But symptomatically, what would tell me if I was a male or a female? Give me the array of them that I should call an HRT clinic or medical or a specialist to get checked out.
You hit the nail on the head where you said anyone over 25, but I'd say even your 20-year-olds, you get a baseline, you know where you're at. It just is such a good, solid panel of blood. But you're looking at, I mean, the most obvious symptom, which not everyone, but some people have, is fatigue. Why are you fatigued? Could it be your hormones? Could it be your vitamin levels are low? Could it be your thyroid hormones? Could it be your sex hormones? Could it be you're anemic? Um, that panel is going to show you just fatigue, fatigue, brain fog, concentrating issues, little memory things, libido, um, what
Visceral
else?
fat, weight
Sleep, yeah,
gain.
weight gain, difficulty losing weight, difficulty putting muscle on, longer recovery time, aches and pains. Even just if you're putting in a solid amount of effort at the gym, you're not seeing results. Why am I not seeing results? All those things are key. So everything from the physical aspects to the mental aspects to everything else, it's all encompassing. The panel will look at a little bit of everything. So patients that don't qualify for testosterone, I say, okay, may not be the testosterone, but let's look at everything else because it's everything else that we're looking at too.
And for females, obviously, a female's a little bit more difficult. I say it all the time to get really like dialed in. We've gotten very, very good at it.
Mm-hmm. Hot flashes.
It's
Oh,
we've actually grown our patient base for females now is like it was like 90-10. Now it's like 70, 70% a male, a balance females, we're in that 25-30% marker, even creeping into the high 30% marker for females out there with their going back to general practitioner, and what we offer. We really urge, especially in your 30s and 40s. But for a female, are there different types of signs than for a male? And when they do go on hormones and they might be heading towards menopause or experiencing menopause, what can they expect from our medical team during that period of time?
totally fair. I'll touch on the more female patients. I think just like you said earlier, the billboard patients walking around, we have the majority of our females are just coming from our male counterparts. They see them and they're like, female looks at their husband, their boyfriend, they're like, what are you doing? Like, I want what you have. Like, why do you feel better? Why do you get this pep? Like, what the heck? And that's where we got the majority of our patients, our female patients. They just said, I want what they have. Like, I just want to freaking feel better. And so when you're thinking about females, you're also thinking about, in addition to the similar symptoms to males, your hot flashes, your night sweats, your just the weight gain, especially around the midsection. Like, why is this happening? Periods are starting to get, more spotty, infrequent, sleep difficulties, just sleeping like crud. Again, back to memory is also important. You're thinking about all of those types of symptoms with females, and then also just I'm expanding on this with medications. You want to be careful, not be careful, but with primary care, they have the XYZ medications they're going to give you. You really want to make sure that they're bioavailable, because the not bioavailable, bioidentical, because the bioidentical progesterone bias, things like that are going to be very different than what you get from your regular OBGYN. Also, we just also keep in mind we're thinking about the health of the patient too. Want to make sure, breast cancers, we're scanning for breast cancers, ovarian cancers, we're talking about those things, making sure you're up to date with your mammograms. If you're not up to date with mammograms, I'm not going to touch you with any hormones until you're up to date with mammograms, up to date with pap smears, any history of ovarian cysts or fibroids or things like that. The females are a little more difficult because they're females. They're always a little more difficult. To me. So just we want to make sure that we are looking into everything and making sure that we're again treating them to the best ability that we can and getting them to feel the best that they can.
So I have patients, just before we fully get wrapped up here, I have patients that call me, they're like, I had these night sweats and hot flashes. It was crazy. And like 5 days after I got my meds, they went away. Why is that happening?
Because you're usually, well, it's not always. Their estrogen and progesterone levels as they get older, unfortunately, they get lower, menopause. Sometimes it's not even just they're getting lower. Sometimes the progesterone levels are low and you're estrogen dominant, and then you feel even worse. So based on where your levels are, we're gonna look at your estrogen, we're gonna look at your testosterone, we're gonna look at your progesterone. Sometimes you'll need just testosterone, sometimes you'll need progesterone and bias, which is basically progesterone and estrogen. And by adjusting your levels to where they need to be, if you are estrogen dominant, you add progesterone, you're not gonna feel that. And then if your estrogen levels are low, you're gonna get the hot flashes, the night sweats. Same thing with progesterone. They go hand in hand. I never do, this is gonna be controversial too. I will never do the estrogen without the progesterone, even if you don't have a uterus. So I might get in trouble for that one. Because they say technically when you have no uterus, you don't need progesterone anymore. But that is crazy because there's progesterone cells in everywhere else, your breasts. So if you go to your mainstream doctor, they're gonna say, you have no uterus, there's no need for progesterone. But really, estrogen is the gas, progesterone is the brakes. So God forbid risk for breast cancer. If you're on estrogen, estrogen is going to make potential things grow, whereas progesterone is going to hold it in its spot. So if you go to your main doctor, if you have no uterus, there's no need for progesterone, which is really like caveman thinking, which again, I might get in trouble for that, but it really is. It's
I
old
can
school
promise you,
people.
with our team of people, you're not going to get in any trouble for that.
Yeah,
Yeah, I mean,
but they go
it
hand
just
in hand.
makes sense, and I mean, the other side of that is that, like, you know, as a patient, you can make a decision if that's right for you, and then we make a decision if we want to treat you that way, and that's the beauty of this thing, right? We're not telling. When you walk into your GP and that GP tells you, this is crazy to me, you have to take all this medication. You walk into the VA, take all this medication. What do? They take it all, right?
Yeah.
Most of the time, they take it all. But you know, just because they're telling you to take it doesn't mean you should be taking it. Like, there's a lot of things that I see on the VA side of this world that are very scary to me. And you know, drug addiction being formed by certain avenues there, and you know, the VA has a target on my back, which is fine. But the reality of it is we're here to help you. Brianna, I have to tell you, you're amazing. This was like, I know you didn't really want to come on this podcast, but I needed you on this podcast. You're amazing. You're super knowledgeable. You're about to see yourself like all over social media for the next like 3 months. So I hope you're excited about that. And I mean, even the guy that's doing these cuts back here has been glued to his screen, like learned so much. And so thank you so much. And I really do. I love you. And I'm so grateful for you. And we'll talk soon. And be well, honey.
All
Thank
right,
you.
sounds good. Thanks, Sid. Have a good day. Bye.